Thank you, Ruth. I think we've heard two very different community-based approaches. One is looking right or working right in with the schools and training the community members, and one is taking community leaders and training them both with the goal of strengthening, I think both are examples of community-based health professions education. We've talked, you've both touched actually on the challenges of scaling, but both, they might be time, resources, contextualizing, et cetera. I wonder if you could speak a little bit about the enablers of spreading, because it's the spread where you both have taken your programs and spread them across geography and across contexts. And what were the enablers that allowed that to happen?
So one I would describe as
the mic.
Sorry, thanks. One I would characterize as the right timing. That in my observation, uptake is better. Maybe readiness would be the right way to characterize it. That people seek solutions rather than trying to build them themselves when the moment is now and there's some sense of urgency about getting something in place, and they feel pretty viscerally that this is an important thing to do. It's why I increasingly think that things like learning networks and connecting people to each other in other places, because the moment that you're ready, if you've already got that network of relationships of people that you can turn to, the chances are that you're going to ask the question, what could I do about this, that from the learning that has come before me.
And I guess I would have to echo that, Ruth. The MHF program is a program that we don't solicit. So everywhere we've taught it, which is 21 countries now outside the U.S., they've asked for the training, so they're primed for it. They're ready for it. Going into the community that you work in, getting sanctioned from as high up as you can go is really important. So we get those are our enablers that are promoting the program. It's critically important. And then after that, we work with the on-grounds partner on getting the program ramped up. For example, in Lilongwe, Malawi, it's been taught numerous times. In Bhutan, it's been taught, I think, near 10 times now. Bhutan is a very small country, about the size of West Virginia, very mountainous, foothills of the Himalayas, and travel is very difficult there. So when we have people coming in this past fall that literally rode a donkey for 2 days to come and get the training, we know it's valuable, and that they will take it back to their community and use it.
Okay. I think with that, are there any questions? Lucinda?
Lucinda Main from Colleges of Pharmacy. And this gets a little bit into the weeds, but on the Pueblo example, I don't think anybody argues against the thrust of the triple aim. I mean, everybody wants healthier people, healthier populations at a lower cost. In your schematic, you can't hold the ER and hospital whole in doing that. So in the projection to 2040, and what I'd be fascinated about is the conversation that's happening in the community, especially since we know that in a rural area, a hospital tends to be a major contributor to the workforce.
Yeah, okay, so that's one of the dark, scary places, right? And again, it's an issue of readiness. We've seen in a couple of communities that there are actually some pretty forward-thinking hospital leaders who are well aware that the hospital of the future cannot look like the current state that it's in, and are already thinking, again, in sort of stewardship terms. We're responsible for this massive workforce, and they're going to have to be redeployed in some way, and that is going to have some impact on the economics of the region as a whole, unless we start thinking in a very forward-thinking way now. And so the collaborations that have come together between the healthcare system and and the Chamber of Commerce and other local business leaders, and the possibility of, you saw in the Pueblo scenario, there's a lot of investment going into Pathways to Advantage, which is thinking about education and job training for kids, for families, and for young people in particular, precisely because they're anticipating that many years out that has to be dealt with. So, I don't want to sound like Pollyanna about this. There are a lot of communities in which what hospitals are doing is either digging their head in the sand or figuring, I'm going to still be there, my competitors will not, and that's how I'm going to operate. That's how I'm going to operate at the moment. They're not all, I mean, multi-hospital systems are not all operating that way. But, you know, one of the messages that comes out of the model each time that we work on it with groups is that there are many of these strategies that take a lot of waste out of the healthcare system. And what a lot of structures are about is taking that savings and returning it to the providers, who indeed did the work to take the waste out of the system, and also returning some of it to the payers. Well, what if there was a piece of that that was also going to the community and investing in some of these other upstream drivers of population health? And that's when you see scenarios that have the kind of dashboard that Pueblo accomplished there, which is it becomes a self-sustaining system, because some of the work that you're doing in the short run is enabling you to fund over the long haul the things that deliver population health. So that is very much the nature of the conversation that needs to happen, and it's why the upfront work about inviting people to the table to be stewards, not to be stewards for the community, not representatives of their organization, and how you compose that group and how you construe its purpose and the norms of conduct and how they work together is critical for how those conversations happen.
Can I add to that? Oh.
Go ahead.
I'd just like to add to that for a moment. In the development of the Mental Health Facilitator Program, which was initiated back in 05, 06 with some meetings with the Department of Mental Health, World Health Organization in Geneva, we made, in the development of the curriculum, very clear strategic move to include all mental health professions and not just psychiatry. WHO, is a medical organization of, as you know, the United Nations, and they're largely psychiatrists. And we were very clear not to use only psychiatry. We did have 2 psychiatrists involved during the entire development of the curriculum. But we also used psychiatric nurses from the islands, a counselor educator from Botswana. We had people from, I think, 6 different continents working on this curriculum, trying to narrow it down to what are the basic, essential mental health skills that people need to know on the streets to identify, recognize mental health problems, and get people help. One of the fundamental problems with that is, in some places, there is no help. For example, again, Malawi, one of the poorest countries in the world. You can drive 10 minutes out of Lilongwe at night, and it's all stars. I mean, there's no electricity. So there's also no physicians and no nurses. The nurse, I think, is in some of the villages a half a day a week. So the entire term I used in the paper that I think was online was the professional silos. We really tried to avoid those. They get very complicated when you're working in at the community, grassroots, in the trenches level, getting people involved. If it's all physicians or all psychiatrists or all nurses or all school teachers, it doesn't work well. The piloting program we just finished all spring in Winston-Salem, North Carolina, was with school counselors, school teachers, school psychologists, and school social workers in the entire administration. And I had to go to the top and get their sanction back 1 year ago to start piloting the educators edition of mental health training. So anyway, I just wanted to share that. It's really important that everyone, all the different facets of mental health are included.
So a question for both of you from different perspectives. One of the things we've been talking about are barriers, accreditation, licensure, and legality as both barriers and drivers of change and scaling. And I'm wondering if you could comment on what strategies we need to take around licensure, for example, with respect to mental health facilitators, and around antitrust law and the kinds of things that would affect systems working together, because it's really those things, if we can come up with an affirmative strategy for dealing with those rather than letting them inhibit us, it would be key for the future. So I'm curious whether you have wisdom to share. Okay,
I'll just very briefly, we don't really have the licensure issue in terms of, medical license, a counseling license, et cetera, with mental health facilitation, because it's like, CPR training. The ASAP program is an 8-hour training. Folks would come in, we would, give them the instruction, and we do role playings. We go over about 18 or 19 different aspects of mental health, and then we send them on their way. So we wouldn't be licensed these people. But you did bring up another word that's related, which is barriers. And that is a big deal with the kind of work I do. So I have a few questions for you guys. The first one is, how many of you ever had a cold? Come on, I want to see some hands. Have you had a cold? Okay. How many of you have ever gotten cut where you need, okay. How many have ever been so sick you had to go see a doctor? How many of you been depressed? Well, you guys are a pretty good group, because I counted the numbers earlier, and it should be about 15 to 18 hands went up just out of this group. So what I'm getting at in terms of the major barrier with mental health treatment and education is stigma and discrimination. We have people, for example, 40% of people in the United States, this is the most developed country in the world, 40% of the people with serious, severe mental health never get any treatment at all. And the number one barrier is stigma. They do not want to go. They're scared of people like me and you. They don't know what's going to happen to them. And it's even worse with teens, young adolescents, or young adults. The number, it probably goes up to 60% don't get any help. Some stats say as high as 75% because of the stigma, and they're afraid of what's going to happen to them. You talk to any teenager who needs mental health care, and the two things that they're worried about: am I going to get hospitalized, and are my friends going to think I'm crazy? And that's the two aspects that come up. So I just want to throw the barriers issue in, because it's what I deal with in every country that I work in.
I have a question for you after I'm done with the antitrust thing.
You can't ask me questions. No.
I'm not allowed to ask you a question. I'm going to pretend to be audience then. I really appreciated the question because underlying it is a really critical leading change skill. It's to ask the question, what policy is going to get in my way, and what are some strategies that I might use to at least explore the next step? And we've seen real differences in groups that say, no, we just can't meet. It's an antitrust issue. We'd get in trouble. And so it doesn't happen. Whereas other groups asked that question and realized that if they had the Attorney General of the state convene them and define their purpose in a way that put some limitations on what they could and couldn't talk about, that was it. And they've been able to meet ever since then. And it's not, that one turns out not even to be a particularly significant barrier, but it's sort of a policy stance that has kept other groups from convening for that reason. So the question I have for you is one about spread. I was curious when you were talking about your work. The U.S. is full of communities that have inadequate resources around mental health. Your program seems, because you've got this train the trainer approach, seems eminently scalable. That there should be many communities who are calling for it. Is that happening? And what do you think you're likely to run into if you answer that call?
It is happening, and we are prepared and ready to answer the call. The curriculum is, we have 3 curriculums that are available. That's the mental health facilitator, the basic one for communities, the mental health facilitator for educators, and then the 8-hour one that's, nice and short. We have taught the training in the United States now, and the towns that I can remember, and these are other trainers that I've trained have done this work, but in Detroit, Phoenix, El Paso, Juarez, Las Vegas, I think San Diego, Salt Lake City, Greensboro, North Carolina, of course, I believe Chicago, just in the last 18 months. So we vet as many trainers as we can, and I agree with you completely. It's something that's easily scalable. This is not real difficult work. It's just what people need to know. You need to be able to identify these things. We have an aging population. People are starting to have cognitive slippage in terms of, pre-dementia. Families aren't noticing this. There are medications that can help this type of thing. So the program is just very simple. You know, we have three acronyms in a 24-hour training. One is AISR, assess, identify, support, and refer. The other one is SNAP, supporting people, what are their needs, what are their abilities, and what are their preferences. And then the last one is STPC. What's the situation? What have you tried? What are your preferences or possibilities? And let's make a choice. And then supporting these people. And then wrapped around all of that is the contextualized part and a basic mental health education. We go over, this is what a psychosis is. This is what an anxiety is, post-traumatic stress disorder, domestic violence, child sexual abuse, physical abuse, neglect, worker stress. And this is what it looks like. This is how it gets identified. We teach them some basic questioning skills, reflecting, what questions not to ask people, how to be supportive, and to get them help and follow up. And that's, you know, you guys are all trained now. You know, that's the essence of the training. And and we train anyone who can walk in off the street. We've trained police officers, firemen, pharmacists. I've even had 2 psychiatrists in my classes in the past, a couple doctors, lots of educators. And as you may know by now, very passionate about mental health with children and adolescents. 1/2 of all adult mental health problems that are diagnosable were evident by the age of 14. And these people go to school every day. Every day they go to school. Kids spend most of their time at school. They talk to their peers, they talk to their teachers. And it's really important to get this education across to educators in our public school system.
So I have 2 questions for you, Scott. One, who invites you or this facilitator training to the different countries? You said you've been to Botswana and you have been on the borders of Syria and Jordan. So that's the first question. The second is, who pays for it?
2 really good questions. The first one, I don't know all the answers to because I don't administer the program. I just do the training and train the trainers. I'm kind of the in the trenches guy, if you will. But I do know, so I can answer that question with Syria. That was done by, we got a call from the Mercy Corps in Portland, Oregon, to go and do the training there. We were going to Lebanon, but it got too dangerous. They were shooting at the planes. So we went to Amman, Jordan, and we flew the Lebanese trainers there. And who pays for all this? So far, the NBCC International and the National Board for Certified Counselors Foundation has granted the money to do all the training. We've done this, again, in 21 countries outside the United States, mostly, I would say 99% self-paid. So we're very passionate about this. One of the rules we have, which is hard, fast, and unbreakable, is we do not go into a country and leave. Most NGOs do that. They go in, it's 3 ahas and a cloud of dust, and they're gone. And we do not do that. If we do not have a sustainable partner, we don't go. So funding, as I was saying earlier, funding is a major issue. I know, maybe I'll put on my soliciting hat. I've heard NIH and NIMH and all this stuff today. We would love to get on some of those grants so we can, help us get the word out. We can only do so much. I think there are only like 6 of us in NBCC International. And you can imagine in 6 years, we've taught this in 21 countries. We're very motivated and just, looking for some opportunities to help get it spread. So thank you for that.
Can I add to the question about who approaches us? I'm Wendy Schweiger, and I work with NBCC International, and I lead the administration of this worldwide. I work very closely with Scott on the program. The people come to, as Scott said, people come to us when they want this training. It's very much word of mouth. It's amazing how small the world really is. And it seems to happen when certain stakeholders in the country, based on the reality of how mental health care as it is, come to us because they find out about the training. For example, in Tanzania, it's a very Roman Catholic country. Much of what we would think of as the counseling and the mental health care is being done by priests. And so a diocese came to us from Tanzania and said, we want our priests to understand better what it is they're doing when they're working with people. We want our seminarians to understand better. We have a partnership with a diocese there, and that's what they're doing. In Malawi, it was guidance teachers, what we think of as school counselors here. The center that we work with there, it's a guidance and counseling center, identified that they felt like their guidance teachers could use more training to deal with the realities of what they're dealing with children in the schools. That's what they're using the training for. The training's very flexible, and we want our partners to choose where they most need to apply it and where they most need to use it.
Great, thank you for that, Wendy. I'm gonna go over there.
I'm wondering whether we could make a connection between this kind of training and the health literacy issue we raised earlier today. Do you have any comments on that?
Do you?
The reason I asked the question
go
is
ahead.
that it seems to me that the kind of basic mental health training that you're offering through this program is something we've deprived the general public from knowing. You can think about that on a global scale, but even in the United States, I would say that these kinds of concepts are not part of basic understanding in our populations.
Yeah, my only comment on it is I was reflecting after I'd heard about your work earlier that we did some work with a campaign in Columbia, South Carolina, who are investing in developing health coaches for the community. And I can't imagine that this wouldn't be a wonderful parallel activity for them to be doing for the same population.
And something I'll add to that, this is a true story. I was giving this training in Bulgaria maybe 4 or 5 years ago. And when I got there, I was met by the on-ground partner, and they asked me the evening before we started if I would not use the word mental health during the mental health facilitator training. This is true. And I said, you got to be kidding me. I just flew all the way here. So anyway, they were very serious. And they started off the morning with, they don't have mental health problems here in Bulgaria. So I just went with the resistance and kind of, placated them for a while. And we had a break. And then I went outside to talk with these two folks. And there was a situation right under the stoop of the University of Sofia. So I brought the whole class to the window and let them take turns looking down on the sidewalk. And I said, what is that? That looks like a mental health problem to me. And there's a guy just sprawled out on the sidewalk, just, completely unconscious. Clearly a street person. And we came back in, and it was the hardest group I've ever taught. And interestingly enough, the reason I'm sharing this is since then, they have started clubs in the community where drop-in teen centers for drug and alcohol abuse problems, parenting problems, et cetera. So they went from asking me not to mention mental health at all to starting these clubs, which I've heard about anecdotally through some from one of the trainers that comes to the States once a year. So mental health literacy is a major issue. I'm in rooms with people that don't know the kind of work I do, and I hear something like major depression and what have you, and just watch everybody just get all tensed up. And then, that's why I was asking you, how many of you have been depressed? Most of us at some time have, but people won't say that they have. I mean, almost everyone has had suicidal ideation at some time in their life. At some time we got in such despair, we just wanted to end it all. You can ask people about that, and they'll say, no, I've never thought that way. And there are a lot of other questions you can ask people, too, that they won't admit to. But so the mental health literacy is really important, and I'm not going to ask you those questions, so you can relax. But it's really important. That's part of mental health. The first module in mental health facilitator training is investing in mental health. Why is this important? When I go into the school system and I'm trying to convince a principal to do the training, I've got to talk about how it gets, it cuts down on on absenteeism, dropout. It makes your teacher's job easier if you don't have someone who's disruptive. 50% of the kids who have ongoing mental health problems drop out of school. They do not stay in school. So now they're in the, no work for, here we go. It's a snowball rolling to where. So it's really important to get that mental health, just the terminology and the education across to the general public. Look at how many teachers and parents could help so many people in the community if they just had this basic information. And people are afraid to ask. Stigma is just with a big S with mental health. And it's worldwide. It's no different here than it is anywhere else.
That's excellent. Before we go to the next question, I just one thought. I'm thinking that, what we are saying also is that we need to identify platforms to identify these good practices and then to identify partners for the last mile. So if there are already health coaches or community health workers in the community, how can we train them in these good and best practices. And that's one of the things we've seen in MEPI, that by creating these technical working groups, we've created a forum both virtually and in person where people are trying to now see and hear about good practices that can be shared.
That might be one of the answers to my question. This question's for Ruth. I'm Maria Tassoni from the Canadian Collaborative. And the raison d'etre for our collaborative is to actually create a pilot collaborative change leadership program aimed at senior leaders. So I was really struck by many of your comments. We're just in the pilot with a cohort of senior leaders in Canada. And one of the things in our first session, our first face-to-face session, we do have a virtual community of this group, was this question of, this is the way to lead, and it's not the norm. This is not how we lead in our traditional systems. This is not the way we teach leadership. So how do I stay resilient? How do I lead in this way in a traditional system? Then I was thinking of Warren's picture of Roger's theory of diffusion. And I'm curious, just based on your experience, this is a question we're grappling with, what is it going to take to get us to the tipping point of the kind of leadership that's needed to truly transform the systems we're talking about?
That's a great question. Yeah, it's always very interesting to me to see when these multi-stakeholder groups come together. There are certain institutions, healthcare is one of them, that is very hierarchical. It's very individualistic in the way that leadership is exercised, and it's very countercultural to do true collaboration. You can usually get a veneer of politeness and a sort of consensus in public that then doesn't actually get I see you recognize this, that doesn't actually get enacted when they go back, but to actually lead interdependently is a whole different deal. A couple of answers to that. One is when you do leadership development programs, bringing people as an intact cohort, as a group, and so that they have the social support of people with whom they develop and practice these practices, because organizations have immune systems and wipe out the foreign body, right, when it comes back, unless there's enough of an infection to keep it going. Sorry. There are organizations there are organizations in the context that already do have some collaborative leadership practices in their system, in their way of doing things, and they can actually help really support the normative culture. The more that you're building the networks across these organizations, the more that you get a sort of new culture and habitual routine developing across them. A tipping point. Some things have to be changed, I think, in the design and structure of the hierarchical organizations, because all you're going to be doing is continually fighting against the hierarchical design, the status differences among people who come into the system, the very individualistic jobs, the fact that when they go back to run their department or run their organization, they're not expected to lead collaboratively there. So having some impact on the home institutions and possibly even building something into your curriculum about how to exercise influence on your home culture. I mean, it's typically your senior leaders that are best able to do that.
I want to thank this panel for both your presentations, but then this discussion that has followed. So thank you very, very much. And we're now going to switch panels. We'll give people a moment to switch. And we have Jillian Barclay from the Aetna Foundation, who's going to be leading the panel on technology and innovations in community-based HPE. I'm going to let her introduce her panelists.